His ears are clear, so why does he keep pulling at it?
That's a really good question, and the answer isn't what most parents expect. Welcome to Medical Voices. I'm Tom.
And I'm Nadia. Welcome back.
Quick reminder before we start. Everything on this show is here to help you learn the language of healthcare. We're passionate about medical English, but we're not giving medical advice. If anything sounds clinical, that's on purpose. It's language, not a diagnosis.
So what are we doing today?
Episode 10. A Pediatric GP Consultation. A parent brings a young child to the doctor with a cough, a mild fever, and a sore ear. We're setting this in a UK GP surgery, which is one of the most directly testable settings for OET speaking. Pediatric scenarios come up frequently in OET role-plays for both the nurse and the doctor profession. The vocabulary works across most systems. Australia and Canada follow a similar GP-led model. In the US, many families see a pediatrician directly, but the language of the consultation is the same.
And if you're preparing for the NMC OSCE, Pediatric assessment is on the blueprint. This one covers you.
10 terms. A full consultation with a 4-year-old. The word today is Pediatric. P-D-A-T-R-I-C. Written P-A-E-D-I-A-T-R-I-C. In UK English, P-E-D-I-A-T-R-I-C in American English. Clinicians shorten it to paeds. We'll use the UK form throughout.
Let's get into it. Before we get into the dialogue, let's make sure we have the right words. 10 terms. Term, definition, 1 example. Pause and repeat whenever you want to.
2 recalls from earlier episodes. We'll flag those when we get there.
Term 1. Pediatric, often shortened to paeds. The branch of medicine concerned with children, typically up to age 16 in UK practice. Example: I'll make a paeds referral.
Term 2. Symptoms. Recall from episode 3 where we built the vocabulary of describing symptoms. In pediatrics, the parent reports for the child. Listen for how Mrs. Carter does it for Oliver. Off his food. Not himself. Gone quiet. Example: Mum, can you tell me when the symptoms started?
Term 3. Fever. Also called a high temperature by parents or pyrexia in clinical notes. In UK practice, typically above 37.5 degrees orally. Example: He felt hot to the touch from yesterday lunchtime.
Term 4. Cough. 2 types matter here. Productive means bringing up phlegm. Dry means no phlegm, often tickly and worse at night. Example: It's a dry cough, mostly at night.
Term 5. Earache. Pain in or around the ear. In young children, the sign is often non-verbal. Pulling or tugging at the ear, irritability, broken sleep. Example: He started pulling at his right ear last night.
Term 6. Examination. Recall from episode 1 when Mr. Davies first saw the GP. Same word today, very different technique. With a 4-year-old, the examination is slower, gentler, sometimes on the parent's lap. Same noun, different choreography. Example: I'd like to do a quick examination, Oliver.
Term 7. Reassurance. The clinical skill of normalizing a parent's worry without minimizing it. Not, it's probably nothing. Reassurance is naming what you found, naming what to watch for, and being clear about when to come back. Example: What I'm seeing is very reassuring.
Term 8. Antipyretic. The clinical term for a fever-reducing medication. Everyday names: paracetamol, ibuprofen. The brand most parents know: Calpol. Example: an antipyretic will help bring the temperature down.
Term 9. Safety netting. The structured set of come back if instructions a clinician gives at the end of a consultation. An NHS coinage now used internationally and explicitly named in OET speaking criteria. Example: let me give you a clear safety netting list before you go.
Term 10. Red flags. The specific symptoms that mean a parent must seek urgent reassessment. Working hard to breathe, drowsy and hard to rouse, refusing all fluids, a non-blanching rash, or a fever that won't settle. Example: I'll go through the red flags so you know exactly what to watch for.
10 terms, every one of them in the dialogue coming up.
Ready when you are.
All right, time for our role play. Today I'll be Mrs. Carter, Oliver's mum. 3 broken nights, 1 grumpy 4-year-old, and that question every parent asks: something or nothing.
And I'll be Dr. Ravi Okafor, a GP at Elmwood Surgery with a special interest in paediatrics.
Let's go! Good morning, Mrs. Carter, and good morning, Oliver.
Thank you for coming to see me today.
Morning, Doctor. Say hello, Oliver. He's a bit shy this morning.
That's absolutely fine. Oliver, I'm Dr. Okafor. I'm going to have a chat with your mum, and then, if it's okay with you, I'll have a little look in your ears and your throat. Nothing scary. Is that all right?
He's nodding. Good lad.
Right, Mrs. Carter. So, what's been going on?
He's had this cough for 3 nights now. Dry, nothing coming up. Mostly at night, keeps waking him up. Then yesterday lunchtime he felt really hot, and last night he started pulling at his right ear. I gave him some Calpol before bed, and it brought the temperature down a bit, but he's been off his food and not really himself today. He's usually charging around. He's gone quiet.
Okay, so 3 nights of a dry cough, worse at night, a fever from yesterday lunchtime, and the ear pulling started last night. Is that right?
Yes.
And in himself, how has he seemed? His energy, his mood?
Tired, clingy. He wanted to be carried in from the car, which he never normally asks for.
Has he been drinking much?
A bit of water. He had some juice this morning, but didn't finish it.
And wet nappies? Or has he been weeing okay if he's out of nappies?
He's been using the toilet for about a year now. He went this morning, so that's fine.
Good. Any noisy breathing? Anything that sounds like a wheeze or like he's working hard to breathe?
No, the cough sounds bad, but his breathing in between seems normal.
Any rash anywhere?
No, nothing.
Any vomiting?
No.
And anyone else unwell at home? Siblings? Partner?
His older sister had a cold about a week ago. That's gone now.
Right, that's really helpful. Let me have a look at him. Oliver, I'm going to start by looking in your mouth. Can you do a big yawn for me? Like a lion.
Go on, Ollie. Big yawn.
Brilliant. Good lad. Throat looks a bit pink and a little bit swollen at the back, Mrs. Carter, but nothing that concerns me. Now, Oliver, I'm going to have a peek in your ears with my little torch. This is the bit that tickles a tiny bit. Ready? 1 ear, then the other.
He's being very brave.
He really is. Right ear, clear. Left ear, clear. Both eardrums look healthy. No sign of infection in either ear.
So why is he pulling at it?
That's a really good question. In children this age, when the throat is sore, the pain can travel up to the ear. We call that referred pain. The ear itself is fine. The discomfort is coming from the throat.
Last bit, Oliver. I'm going to listen to your chest with this. It's a bit cold, sorry. Chest is nice and clear, Mrs. Carter. No crackles, no wheeze, good air entry on both sides.
3 nights of coughing, and now he's pulling at his right ear. I just want to know if it's something or nothing, doctor.
I completely understand. What I'm hearing and seeing is most likely a viral upper respiratory infection. A virus that's making the throat sore and triggering the cough. The ear tugging is probably referred pain from the throat, not an ear infection. The ears actually look healthy.
So no antibiotics?
No. Because this is viral, antibiotics wouldn't help here. They don't work on viruses. What will help is time, fluids, and rest. For the fever and the discomfort, keep doing what you're doing. Paracetamol or ibuprofen, either is fine. Follow the dosing instructions on the bottle. Clinicians call these antipyretics, which is the fancy word for a medicine that brings the temperature down. You know them as Calpol, paracetamol, ibuprofen. Same thing, different names.
Okay.
Plenty of fluids. Water, diluted juice, ice lollies, whatever he'll take. Small and often is better than trying to get him to drink a big cup all at once. Now, Mrs. Carter, I'd like to give you a clear safety netting list. These are the things I want you to watch for. If any one of them happens, bring Oliver straight back to us, or if the surgery is closed, call 111. Ready?
Ready.
If he's working hard to breathe, if he becomes drowsy and hard to rouse, if he refuses all fluids for 8 hours or more, if you see a rash that doesn't go pale when you press a glass against it, if his fever goes above 39 degrees and doesn't come down with paracetamol, or if the fever lasts more than 5 days. Any of those, come back. No apology needed.
Okay, I've got that.
Quick aside, Med Nomads, what's in your standard safety netting list for parents of young children? Drop yours in the comments. The variation country to country is fascinating. Now, to reassure you, Mrs. Carter, most coughs at this age sound much worse than they are. The cough may carry on for another week to 10 days, and that is completely normal. The fever should settle in 24 to 48 hours.
And if he's not better in a few days?
If he's no better in 5 days, or if anything changes before that, bring him back. Book an appointment, walk in, ring us. There's no need to wait if you're worried. But based on what I'm hearing and seeing today, I'd expect him to be back to his usual self within the week.
Thank you, Doctor. That's really clear.
Oliver, you've been a star. Well done, mate.
Okay, now let's do 3 key exchanges. A little more slowly.
Has he been drinking much?
A bit of water. He had some juice this morning, but didn't finish it.
And wet nappies? Or has he been weeing okay if he's out of nappies?
He's been using the toilet for about a year now. He went this morning, so that's fine. I just want to know if it's something or nothing, Doctor.
I completely understand. What I'm hearing and seeing is most likely a viral upper respiratory infection. A virus that's making the throat sore and triggering the cough. The ear tugging is probably referred pain from the throat, not an ear infection. The ears actually look healthy.
So no antibiotics?
No. Because this is viral, antibiotics wouldn't help here. They don't work on viruses. What will help is time, fluids, and rest. For the fever and the discomfort, keep doing what you're doing. Paracetamol or ibuprofen, either is fine. Follow the dosing instructions on the bottle. Clinicians call these antipyretics, which is the fancy word for a medicine that brings the temperature down. You know them as Calpol, paracetamol, ibuprofen. Same thing, different names.
Okay.
Plenty of fluids. Water, diluted juice, ice lollies, whatever he'll take. Small and often is better than trying to get him to drink a big cup all at once.
Now, Mrs. Carter, I'd like to give you a clear safety netting list. These are the things I want you to watch for. If any one of them happens, bring Oliver straight back to us, or if the surgery is closed, call 111. Ready?
Ready?
If he's working hard to breathe, if he becomes drowsy and hard to rouse, if he refuses all fluids for 8 hours or more, if you see a rash that doesn't go pale when you press a glass against it, if his fever goes above 39 degrees and doesn't come down with paracetamol, or if the fever lasts more than 5 days. Any of those, come back. No apology needed.
5 points from that consultation. The language moves that matter. The ones to keep in your ear, and the ones to reach for in OET Speaking and IELTS. Point 1. The Pediatric Register. Talking to the child and the parent. Dr. Okafor used 3 distinct voices. Child-directed language. Can you do a big yawn for me, like a lion? This is the bit that tickles a tiny bit. Parent-directed clinical language. Ears are clear. Both eardrums look healthy. No sign of infection. And parent-directed reassurance. Most coughs at this age sound much worse than they are. 3 registers, 1 consultation. OET examiners listen for exactly this. Can the candidate switch naturally between child, parent, and clinical language without sounding scripted?
Point 2. Reading the body when the child can't tell you. The parent said, off his food, not himself, gone quiet, wanted to be carried. Those are parent observations, not clinical terms, but they are exactly what the GP needs. Pulling at the ear, refusing fluids, loss of energy. At the bedside, these live in plain English. In clinical assessment frameworks, they map onto alertness, fluid intake, and activity level. Translating parent language into clinical assessment is a skill OET Speaking marks explicitly.
Point 3. The structured pediatric history and the order matters. The doctor asked duration first, then fever timing, then the 4 things that signal a sick child: alertness, fluid intake, urine output, breathing. Then rash, then vomiting, then contacts at home. That order is not random. It's the way a GP triages severity quickly. And it's the order an OET speaking candidate should follow in a pediatric scenario. Duration first, red flags early, social context last.
Point 4. Safety netting. Naming the comeback list. This is the moment in the consultation where the doctor hands the responsibility back to the parent, but only after explicitly naming what to look for. If he's working hard to breathe, if he becomes drowsy and hard to rouse, if he refuses all fluids for 8 hours. Clear, specific, memorable. The phrase safety netting is an NHS coinage, now standard internationally. It's one of the highest scoring closing moves in OET speaking for both nurse and doctor profession.
And point 5. Reassurance is not dismissal. It's probably nothing minimizes. What I'm hearing and seeing is most likely a viral illness, and here is exactly what to watch for, reassures. The difference is that the clinical reasoning is made visible. The parent isn't told not to worry. The parent is told why it's safe to go home and given a clear plan for what would change that. That visible reasoning is the OET speaking criterion of providing reasons. Same principle in IELTS healthcare contexts at 6.5 and above. 5 points. That was the breakdown. Now the quiz.
Yes, quiz time. 3 questions. Nadia, ready?
Ready.
Question 1. What does pediatric mean? And what is the common abbreviation a clinician would use on a referral letter or the rota? 5 seconds. Think before you listen.
Pediatric means the branch of medicine concerned with children, typically up to age 16 in UK practice. The abbreviation is paeds. You'll see it on referral letters, on the rota, in handover notes. US spelling drops the AE and writes it PEDIATRIC.
Question 2. Name 3 things on the safety netting list. What should a parent watch for that would mean coming back urgently or calling 111? 5 seconds.
Working hard to breathe, drowsy and hard to rouse, refusing all fluids for 8 hours or more. Also on the list, a rash that doesn't go pale when you press a glass against it, a fever above 39 degrees that doesn't settle, or a fever lasting more than 5 days. Any one of those, bring the child back. No apology needed.
Question 3. What is an antipyretic and what are the everyday names a UK parent would know it by? 5 seconds.
An antipyretic is the clinical term for a fever-reducing medication. The everyday names are paracetamol and ibuprofen. The brand most parents of young children would recognise is Calpol. Same medicine, different register. Clinical word plus everyday word, side by side.
3 questions, 3 clear answers. The PDF transcript has all 10 vocabulary terms, the full dialogue, the language notes, and a sample Pediatric safety netting card. Link in the description.
That's episode 10. Oliver is in good hands, and his mum knows exactly what to watch for. Next week, same kind of worry, very different setting. Episode 11 takes you onto the phone. An after-hours triage call when the surgery is closed, the child is unwell, and every word matters. See you next week, Med Nomads.
See you next week.